One thing that I've always felt proud about in our clinic and our approach is that we don't give up. That is the most important thing, that we don't give up. There's been a tremendous amount of work done in the last 30 years on ME/CFS and in the last few years on long COVID. So there's this new information every single day. And I'm incredibly sad when I hear of patients who are despondent and giving up. You can't reach everybody, but perhaps these podcasts can help people feel like, we're there and we're on your side and we're working like dogs to try to find the answers and we're making progress. It is the worst possible time to give up, the worst possible time.
Hi, I'm Haylie Pomroy. I'm the Assistant Director of the Integrative Medicine Program at the Institute for Neuro-Immune Medicine. We have had such incredible feedback from the podcast that we've put out for you guys. Our goal is to instill hope in those of you and us that are struggling through complex chronic disease, and really to provide you with help when you feel like you can't get it. One of our guests from the first round was Dr. Nancy Klimas, and we got so many questions about all kinds of things. We kind of pulled our community. You guys make sure you're active in our social media. Your questions are what are going to drive our next topics. So we pulled those questions together, and I got Dr. Klimas to come back and give us a whole lot more hope and a whole lot more help. And so, Dr. Klimas, thank you so much for spending some time with me out of your busy clinic today. I really appreciate it.
Happy to be here. Thanks a bunch for having me back.
It's just a great experience. We know that there's so many people, this has really taken off even globally. There's so many people out there that are struggling with a lot of different aspects of complex disease. One thing that our community was really, really wanting to understand about is this whole concept of viral reactivation. And I thought, who better to ask than you? Can you tell us how we can kind of wrap our heads around that concept of viral reactivation?
Absolutely. And it's not a simple topic. And I know why it confuses people, because there's just a lot to it. But let's just start with the facts. If you were to take long COVID for a moment, where there's been a little more work done from the very beginning of the illness through till when people feel sick, these prospective studies. One of the things that predicts who will have long COVID after acute COVID is who reactivates their viruses, or in this case, Epstein-Barr virus. So reactivation viruses means that there are some viruses, not every virus in the planet, but some viruses that we come across in our lifetimes that instead of being gone when we're done with our acute illness, it's burrowed in deep, and they are called latent infections. They're hiding out somewhere in your body, usually in some cell, like your immune system cells is where Epstein-Barr virus is hiding out. So they're just hiding out there. So then you have these viruses, and the one you think about the most is the one that they advertise the most for on TV, shingles, right? Okay. So when you had your measles when you were a kid, your chickenpox when you were a kid, you had this virus that causes shingles. And when it reactivates, it doesn't create total body infection the way it did when you had chickenpox. It doesn't even cause a rash from head to toe. Instead, it hit out in the nerve endings, and it reactivates in your nerve endings, and it hits a cluster of nerves and that distribution of that nerve, and you get that little patch, that rash, and that's a reactivated virus.
So the same virus that causes shingles is the virus that causes chickenpox.
Right.
And when you say it's latent, it means it didn't clear. It didn't leave the body once you got it. It just kind of stayed dormant and hidden somewhere.
It's dormant and hidden from the immune system. So the immune system couldn't see it because it wasn't active. It wasn't making replicating virus, and there was nothing for the immune system to see. But then when it gets all stirred up and active again, now it's making virus, and you want your immune system to knock it down.
When you said EBV or Epstein-Barr virus, the original insult, is that mono?
Yes, exactly. So the chickenpox virus is in a family of viruses called herpes family viruses. You think of herpes, oh my God, I got herpes. But herpes is also the cold sore virus, right? Cold sores. And then there's other herpes family viruses like Epstein-Barr virus, the chickenpox virus, cytomegalovirus. There's a bunch of them. So they are all viruses that can be latent, and they can hide out for your whole long life and maybe never bother you again, or maybe reactivate. And the time when they tend to reactivate is when your immune system is either down because it's been challenged so much that it wiped out its resources, or a time when the immune system's super activated by something else, like some other infection came along and turned everything else on. So we're not really sure, like long COVID, if it was the COVID that just turned it all on, or in your struggle to deal with acute COVID, you knocked out your resources and other stuff started reactivating. But it happened.
Does anybody clear those viruses, or does
No,
everybody?
no.
So no matter what.
100% of people have their old Epstein-Barr virus infection if they ever had it, and 98 point something or other of all of us had it. So just about everybody has Epstein-Barr mononucleosis virus, whether you remember having mono or not, you had it, right?
And so basically these viruses hang out in the body and they're hidden so that the immune system can't take care of them or suppress them, or how does that work?
Well, they just don't get all the way wiped out during the acute infection. They have a way of hiding inside a cell where they can't be seen. And when that cell goes quiet, they go quiet. And now the immune system's not going to see it unless it tries to pop back out again.
Are they starting to think with a situation like COVID and long COVID, are they starting to think that old viruses got excited again, or is the COVID virus still hanging around?
Yeah, that's two different questions. Very different questions.
I'm so glad I get to do that.
So first, thank you so much for challenging me to try to be clear on something that's really murky. But the one thing is, let's just stick with Epstein-Barr. If you had acute COVID as one example, and you reactivated your EBV during acute COVID, then when you look down the stream and you see who's totally gotten over their COVID and who has long COVID, one of the predictors of long COVID is that the EBV reactivated and stayed reactivated. Okay. Just that it didn't pop up during the acute infection, but it didn't clear again. So that would make one reasonable research question to answer would be, if I cleared EBV, would they get better? And we don't know the answer to that question. We haven't done that study yet. We just know that it's a reasonable target. But the other question you asked, did COVID clear? That's even murkier, okay? Because there is some reasonable science done that looks for COVID long after you're over your COVID and you have long COVID. And that group of people that had long COVID, do they still harbor COVID? And in studies that were done like 3 months after the acute COVID or 6 months out after the acute COVID, in compartments you wouldn't expect. When we do COVID, we swab our nose and there it is.
Right.
But it's not in your nose anymore in long COVID. It's in your GI tract. And so it's in the biopsies of the stomach or the intestinal wall where they found COVID. Maybe it's other places, but it's not up your nose anymore. We'd be able to see it really easy. So, but it's down in the gut. So here are these people that have had COVID. Now they have long COVID, and when they go searching for COVID, you say, is there some reason to think that this stuff we're seeing in the gut is real or not? And is it a live virus that's replicating that could be controlled? Or is it just some viral DNA that got stuck somewhere and it's making noise, but maybe not driving the whole problem? So that's one of the big research questions. So we published a paper just in December of 2023, just a little bit ago on this recording, that had a small case series of people who were treated with monoclonal antibody to COVID in people that had long COVID, and they cleared and they got better, all the way better from their long COVID. So now we're about to do a study as soon as we get our FDA approvals to do that study in a much larger group and find out if we're on the right path there.
So I have, every time I interview you, I have this long list of notes that I'm going to ask her next time. I'm going to keep her forever. So I'm going to take it back just for a second. So some people you had mentioned when their EBV can get reactivated, and it can be an infection like we saw with COVID potentially, but it can also be extreme fatigue or exhaustion or stress or something that disrupts.
I was just using COVID as an example because it's such a clean bit of data where they actually looked when someone had the acute infection and found it. But we have this other group of people, the chronic fatigue syndrome or ME/CFS group of people who also reactivate viruses, and not just EBV, but viruses. And we don't know for sure that happened during an acute insult. Many people with this illness say, I had an infection, and ever since that day, I've been sick. And it might have been the flu. I mean, something well characterized, like I had influenza, and now I've got this. or they might have had mono and they never got better from mono. So we don't know if EBV reactivated or any of its cousins during the acute infection that seemed to trigger the whole thing off. And just like long COVID, now they're one of the many mediators of persistence of illness is this darn virus that won't go away. I mean, that is plausible.
So,
But so let me finish, because there have been some clinical trials in ME/CFS to try to clear the viruses. And the bottom line is that we don't have, in my mind's eye, I'm going to interpret this, we don't have as effective enough a tool to clear the infection to know for sure we got rid of it, to know whether or not how much that infection's got to do with the whole illness or not. It's just one of the targets we do, but we don't have the best tools in the whole wide world to get rid of those infections.
Right. And so one of the things that we see a lot in the clinic, and this was one thing that kind of really struck me when I first came in, was how many of our patients that come through have seen many physicians before we're usually not their first stop by any stretch of the imagination. One of the practitioners said it's usually 10 years and 10 doctors, if they're lucky. But I was just going to ask you, would you say it's more so 18, people are 20? Yeah, that's what I was just going to ask you. So it's always shocking to me that I was saying that, that's fine if you're an NFL player or a Major League Baseball or basketball player, and you have a team of doctors that are working towards your wellness, as long as you're getting well. What shocked me was how many people were coming into our clinic that had 10, 20 visits with physicians that weren't changing the health trajectory. I have a few outside positions or ideas on that, but I want to ask you, what are we seeing when patients come in and they've seen other physicians in the past? Are they missing something? Have they not turned over every stone? Is it because they're missing that it has an immune component, or what's going on?
It's partly the siloed way that we do medicine in this country now, which you'll see a cardiologist for your palpitations, and you'll see a GI doctor for your bloating and your GI pain, and
right.
on and on. And you can look at ME/CFS through all those windows, and you can end up with 7 specialists looking at specific symptom sets, but not someone tying them all together and understanding that they are knit together and that there's underlying common causes for all those different symptoms. So that's part of it. Part of it is the science that results in evidence-based guidelines. So if you don't do all this expensive research, really price tag, high price tags, millions of dollars worth of work to prove that the majority of the patients have this biomarker or that thing or this thing or that thing, then we can't teach primary care doctors how to look. I don't have enough evidence to write the paper that says do this first and this second. And so instead we end up with just not enough information in the hands of the people you tend to see at first. We have tried to solve that. We have a website called ME/CFS Clinicians Coalition. It's a group of doctors with a lot of years of experience. I mean, many hundreds of years in that great big group of people that have been doing this for decades, that put their heads together and tried to write at least some guidelines out from clinical experience. And that helps prioritize the research to create the evidence behind those guidelines and make them even more solid. So there are some places to go. You can, if you're a patient and that your doctor doesn't have a clue, you can go to the ME/CFS Clinicians Coalition website and you can find some stuff you can print out and bring to your doctor about how to approach the problem.
That's what I was just going to ask. So if there's a person out there that's not in our clinic and they want to have this conversation with their doctor, so they can go there, and there's some really good data on that. How does someone test for EBV reactivation? Is it an immune lab? Is it a traditional lab? How do they find when we see?
They're actually pretty easy to test for. I'm going to put an ad on to the places you can go besides the coalition, and maybe you could do this with in your thing with some links.
Yeah.
The CDC has a nice website, as does the NIH, on at least the diagnostics part for MEC. Okay. And long COVID, that's a changing under your feet place, but there's actually some go there as well. But so at least to get the diagnosis right. That may not get you your management plan, but it would at least get you in the right pocket.
And is testing for viruses part of that diagnostics?
It is. It's interesting that I was on a panel, the Institute of Medicine panel, that developed the current case definition for ME/CFS. And even this expert group couldn't quite agree on how strongly they felt about that data. But there were clearly very passionate experts in that group that were saying, how could you possibly not look for viral reactivation in this illness? It's a critical feature of the illness. So you asked the question, how do you look? So one of the strongest things you could ever do to look for a virus is to use PCR, which is a way of looking for the virus itself.
We heard a lot about that during the pandemic. We all became, what's PCR?
Yeah, exactly. Why are they PCRing my nasal?
Yes.
Gross. There's viruses on that. But there were viruses on that, and you were measuring the viruses,
Okay.
Things on the viruses that are only not your immune response to the virus. You were measuring the virus itself, right?
Right.
So
we're looking for particles or whole viruses?
That doesn't tell the difference. It only tells what the target was. So you only tell if you have a whole virus if you take it, culture it, and infect something else with it. No one does that.
No.
So
unless with mono and you give it to your friend. That happens.
Yeah, and the whole house got sick. It was a virus. There you go. But no, that's not true with ME/CFS or long COVID. You can't make anyone sick by being around them.
It's not contagious. Absolutely.
To be clear, I did not say that.
No. Absolutely.
Super clear. It is not contagious. But what was I saying? I was saying that the PCR. So PCR is a way to look for the virus itself. But to do that, you have to look for the place the virus is. Okay.
Got it.
So we're lucky Epstein-Barr virus circulates in the bloodstream. But other viruses that reactivate in ME/CFS do not. And there's one that is called, it's Coxsackie virus. It's an enterovirus. It's in your intestines. It's in the walls of your intestine. And you're not going to see it in a blood test by PCR. You will not see it. So the one way we get around this business of not knowing where the virus is to look for its immune signature, because the immune system is circulating all the time. And if you made antibody to something, it could have been the brain or your prostate. Who knows? It's going to be somewhere. No,
so that's when they do. Yes, no, not mine. Only my male friends.
There you go. But anyway, I'm teasing you. But
no, I love it.
And is that you need to know where if you don't know where to look, but you know what to look for, that's a big if. Let me put that right out there. That's a big if. But if you know what to look for. So we know some viruses that reactivate and consistently, if you had cancer, if you had HIV, what viruses would reactivate? Epstein-Barr, cytomegalovirus, HHV6 virus, and then some of these Coxsackie viruses that get into your muscle and into your gut. And those are the ones that we've looked for and we've found them. Okay.
Right.
Now, what haven't we looked for? I don't know. The things we didn't know how to look for, but they're out there. We don't know the name of everything. But they're like our flag. If this happened and your immune system let this happen, it's going to let other things happen too. So can you deal with it by treating the infection that you found? Or do you have to fix the immune system? So that's what I was just going to ask. Huge deal, right? Because if I had a magic button to fix your immune system, wouldn't that be sweet? I would get to change professions. I'm an immunologist and I would like to move into something else. But that magic potion doesn't really exist. But there are things we can do to strengthen the immune system. And there are things we can do that target a specific virus that we're going after, or less specific things that can be antiviral. So take an example, your immune system makes something called interferon. It's an antiviral. It hits all the viruses. It's an antiviral that does everything. And why did that evolve? Well, that's pretty cool. Little trick your immune system knows how to do to have an antiviral for anything that comes along. So if really specific ones can actually be a good idea or a bad idea.
Right. If someone's out there right now and let's say they're having antibody testing, right? That's what the blood testing usually is for EBV and maybe in a traditional doctor's office. One of the questions that our community asked was they had a friend that had gone through some really good care and they were sharing stories of similar symptoms. And they had run an EBV or Epstein-Barr virus antibody test through the blood. And their antibodies were really, really high. Was the antibodies that were IgG and the antibodies that were IgM. This was a person, we were having this conversation. Their doctor's response was that because the IgM was normal and the IgG was like 1700, I mean, it was way, way high, that just means that they had had an infection in the past. And it didn't give any indication that there was still virus.
Right. So that's sort of something that the way I learned it in medical school a long time ago. How many years was that?
A couple years ago.
Right. And that hasn't changed, that same thing. But if you think about the immune system, it's quite different than that. Okay. The immune system makes an antibody response when you have an acute infection. It goes way high. Okay. The second time you see it, you got memory for that. And it goes higher still because it's got all this cool capacity now to be responding really, really, really vigorously to things you've seen before. You made a memory. Wow. So think about it. When you have an acute infection, you go way high and you make antibodies to all different parts of the virus. And that pattern of antibodies they show in the Epstein-Barr virus panel, some is VCA, viral capsid antigen. That means it's outside of the antibody of the virus. Nuclear antigen antibody, which is in the inside. So think about that. I'm going to make antibody to the stuff on the outside a lot. And it's going to be my first round of protection. It's the first thing I see. Right. So when you make an antibody response to Epstein-Barr virus, this capsid antibody is going to be up and it's going to stay up forever, but it's going to go down, down, down over time and be low unless you see it again. It goes back up it goes. Okay. So when you see these rock and roll antibody titers to Epstein-Barr virus, that's not saying old. That's saying, oh, it got quiet and it came out and it got quiet and it came out and your immune system did what it was supposed to do and make a bigger bump there. If you see the nuclear, the inside stuff, that means you made so much of it. It was broken up. Pieces were out there. Wow. The immune system. It's not a whole virus. It's a busted up virus that let you see the inside. And that's even more of a suggestion that you reactivated your virus.
So in our community, we do this thing called a request for care, which helps people get organized for a doctor's visit and helps them articulate some of the nomenclature or the conversation. What would a person ask for if they wanted to have their, let's use EBV as the example, their viral load checked? Would they just, I hate to send somebody in that says, I'd like to be tested for Epstein-Barr virus. Is there 4 or 5 specific tests?
Just two that you can get it out of, any of the large national labs. One is PCR for Epstein-Barr. Okay. It's a checkbox on their little checkbox thing. And the other is the Epstein-Barr virus panel, not just one test, but the whole panel. Okay. Which is IgG and IgM to that outside thing capsid, and nuclear antigen is Epstein-Barr virus nuclear antigen.
What is the VACA that I've seen? Is that different than the IgG IgM?
Say that again. What was the
I think it's called the VACA, the
VCA.
Yeah, the VCA.
That's viral capsid antigen. That's outside. Okay.
Is that part of the IgM IgG testing, or is that separate?
Two things. So you're doing IgG and IgM. It's all in the panel, right? So the panel is IgG to VCA, IgG to EB nuclear antigen. Okay. And then it has the IgM to VCA. And the IgM to VCA is supposed to be, and this is what you're going to medical school, an acute response antibody that only happens during acute infection. Were that the case, you would never see it in someone my age because I had mine back when I was in my 20s, right? But I do see it in people my age. I see it in people that are way, way, way past their primary infection. Therefore, what we learned in medical school was wrong, 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 wrong. Okay.
I love it.
To say that it's exactly what I learned. And they're not even saying this anymore. Though some of us with old memories pass them down generationally.
Yes.
And that's bad. And the
but now we're all learning. So this is wonderful.
Yeah, exactly. So another point, IgM is always wrong. If you have IgM, there was a virus very recently. Okay. And if you have IgG at a very high titer, you had virus sometime in the recent past, not necessarily today, but sometime in the last 3-4 months, you kicked that sucker up. Okay. IgM, you kicked it up in the last few weeks. And the virus itself, PCR, you got the virus right now. You just found it. Okay.
Wow.
That's what it tells you. So
that's great.
yeah, then
Well,
you
I'm going to
say, okay, you do that virus by virus. You don't have to do it with just one virus. HHV6 is actually the most common virus we see. HHV6 virus, which is back your 3-day measles virus when you were 2.
Okay.
So another reactivation virus. We see that way more often by PCR and by antibody titers than any other virus.
And is that the same, that you would look at the capsid and the nuclear, both in those two?
They don't have the advantage of offering such a nice test in the, right? Those are just like IgM and IgG tests that they offer.
Got it.
Yeah.
PCR, IgM, IgG.
Yeah. PCR.
Yes.
Separate. IgG, IgM separate.
That's great.
Yeah. But then they don't offer the whole panel. I wish they did. That would be super helpful.
So we have a specialty lab where we check not just the virus and our immune system's response to the virus, but we check our immune modulation and our immune system pretty expansively. I mean, it's amazing. Is that something, are there some traditional, like the flow cytometry used to be so hard to get back when I first started, and I've seen it more available. Are there things that have come to the forefront that's more available that people can ask their doctors to run if they're concerned about their immune system?
Yes and no. So again, the more national labs out there don't have as elaborate or as clearly focused panels on chronic fatigue syndrome or long COVID. There's a few that have some panels, but the panels in long COVID actually are a little bit different than MECFS panels. Anyway, our laboratory does cytokine panels, so they can tell you what the state of your inflammatory responses and your antiviral responses and your autoimmune or allergy responses. It can give you a sense of that from the way your body makes its signaling systems, cytokines for signaling for that kind of thing. And then you have flow cytometry that you described, which tells us in the simplest way in any lab, do you have enough of the main cells in your immune system? And that's a good enough question to ask. It's not a bad question. But, and honestly, the labs offer them and have offered them since AIDS, because we had to follow CD4 cells all the way through HIV and still do for HIV. So, so these panels are widely available. Our lab goes a big step further and looks at the state of your immune activation. Is it chronic immune activation, immune senescence, which is what happens if you push the on button on for too long in your immune system. It's sort of like an early aging thing.
That's what I was just going to say. These cells kind of rapidly age and aren't as powerful or as effective, from what I understand.
But they are recoverable.
So one of the things that I notice is that in our clinic, by running these, it really seems to shorten what is going on in the body versus how are we going to treat this body. That set of data that comes out of our lab gives us a good indication of not just what is the virus doing, but what is the body doing about the viruses. And I think it really helps, working with the docs that I've gotten to in the clinic, it really helps formulate a treatment plan a lot quicker than when maybe you're just looking at what the virus is doing in the body versus what the body's doing about it.
It tells you some things. Some of the things that happen when the immune system's in this chronic on position, overactivated and charged up all the time, is it exhausts. It's called immune exhaustion. But in doing that, you think, well, why would that happen? Well, it can use up some of the stuff it needed to do what its job might be. And if you look then nutritionally with things with nutrition lab markers, you might discover that they have a lot of oxidative stress, and they might have way too little of the things that you use to make cellular energy. And you can feed that. You can feed that with food, and you can feed that with supplements. So there's things we can do when we know there's something broken. And it might be another layer of the onion. You might look here first to say, oh, look, this immune system's really been messed up, and it's not clearing viruses, and it's not doing its job well enough. Well, why would that be? And then you do another layer and see if you can find something that you can fix underneath all that. And sometimes the thing to do, as we learned in HIV, is to stop the virus for a while and let the immune system recharge.
Rebalance itself,
so the
right.
immune system sort of needs to, it's just like a leaking bucket. If you plug the hole in the bucket and let it come back up, then
Yes.
now it's a really fully charged immune system up, be able to sustain the level of viral reactivation that you were living with and get it knocked down on its own without any more help. So sometimes you might use an antiviral for a period of time just to get it all a little quieter out there.
Things kind of under control.
Yeah.
So in everybody asking all kinds of questions in our community, I definitely wanted to touch base about the viral piece and viral reactivation. And I just want to, I know you're busy. I want to ask you 80 more questions, but I've got one more that I want to just hit, which is, I noticed that we like to look at things from a variety of different perspectives when people come into our clinic. And I know that a lot of that has to do with the fact that we have the ability and the capability to do phenomenal research, both, from bench to bed, but also from a computational perspective, look at the numbers, see what sets are doing, look for trends. The treatment approach in our clinic, though, uses a variety, an expansive number of therapies. And I think that that's some of the reason why we get people that have seen, 10, 20 plus physicians in the past, is because maybe it was a singular therapy that was suggested for a very complex disease. Why in our practice do we do such an expansive treatment plan for people that gets them well? Why can't we just give one thing?
Well, that's interesting because, one of the things we have done with your tax dollars, thank you, is to try to figure out all the modeling of what's underneath this illness. And one of the things, our way of approaching it, is to understand why someone could get into a chronic sick balance and be balanced. This is how I am every single day. I'm not getting worse. I'm not getting better. I'm just in this new sick, steady state. Well, that infers homeostasis, that the things that keep us in balance are balancing you over here. So when we do our incredible modeling work, which is crazy cool what we do, you can not even imagine, wrong podcast, but in the end, we have this place where you're balanced healthy and place where you're balanced sick. And what's between is a mountain that you can't just draw a straight line. I can't just fix one little button over here and expect all this to get right. That's crazy, because this is an imbalance of your endocrine system, your immune system, your autonomic system, your neuroinflammatory and oxidative stress systems. They're all engaged in this chronic, nasty, miserable, chronic, stable illness. So I can't fix one thing to get there. I actually have to climb a mountain of fixings and roll them back down into this old steady state to hope to get you well enough. So that's sort of the plan. So yeah, it's never going to be one button. And all of our modeling says, and these are really crazy models where you do supercomputing for 5 weeks and 5 machines with all the data in the whole wide world and try to reboot the platforms back to where it was. It's never one button. It's always at least 2, if not 3 systems worth of buttons that you have to press to get them climbing that mountain and pulling back down the other side.
Dr. Klimas, what you just said right now just gives a level of, I'm going to use the word permission, I guess, for people out there that are struggling to really persevere to find out the why and to understand their bodies more and understand what's happening to their bodies. Because when you said a homeostasis of illness, so many times people go in and maybe their labs even come back normal, right? Their traditional labs, their CBCs, their cholesterol's okay, their hemoglobin A1C, and they get told, you're fine. That's what this whole, it's all in your head, when many years ago, we hope it's many way behind us with chronic fatigue and a lot of these complex diseases. But that a body can actually strike and kind of has to, so we don't expire, but a position of balance in the state of illness, and that it takes energy and effort to kind of climb that mountain. So we want to infuse our patients with knowledge, with hope, with resources, with nutraceuticals, with good food, with good thoughts, with acupuncture, with well-researched.
The things that help, and the things we've experienced do help. There's a logic behind what we do. It's not like we're just randomly hitting different buttons and hoping we hit on the right thing. But there is also a very personalized approach, because every person's different. You may all feel sick in the same way or almost the same way, but what sustains you there can be quite different.
Right. And your mountain's different than my mountain.
Exactly right. So we're really, as a research group, working hard to personalize at a research level a model for each individual patient that comes in. That's one of our big goals, is to be able to put your data into the platform and have it algorithmically tell us how to approach this problem.
Right.
But where we are as clinicians with the umpteen zillion years of experience, and it's been a lot, I'm not going to go all the way how old I am, but really, I'm not the only one. And we have a lot of years of experience behind us. And experience matters. We do know. One thing that I've always felt proud about in our clinic and our approach is that we don't give up. That is the most important thing, that we don't give up.
Right.
And so the one approach works, okay, great. If it doesn't work, okay, there's another approach.
It's data. It's good data. If it works,
yeah, exactly.
Right.
I always tell people who tried 5 SSRIs, why do you keep trying SSRIs? What's the deal? Stop with the SSRIs already.
Right.
Well, that's a type of antidepressant, and there's a bunch. You can go through all of them, but why would anyone really
be that much different? Well, so Dr. Klimas, you just said we don't give up, and we don't want any of the listeners out there to give up. I want each and every one of you. We are.
I'm trying to say exactly that. We don't give up. So if you give up, that's so sad, because there's so many reasons not to give up. There's been a tremendous amount of work done in the last 30 years on ME/CFS, and in the last few years on long COVID. Right. There's never been more money, at least in long COVID, let's put it clear, to try to come up with the answers and flush a huge number of new investigators into the field, thanks to massive funding that came from our Congress. And we are grateful to our Congress for putting the money down that spot. So there's this new information every single day. And I'm incredibly sad when I hear of patients who are despondent and giving up, because people I don't know that I read about in social media and stuff. And I think, you can't reach everybody, but perhaps these podcasts can help people feel like, we're there and we're on your side, and we're working like dogs to try to find the answers, and we're making progress. It is the worst possible time to give up, the worst possible time.
Right. And I think that was really, as we have this Friday clinicals where, like you said, there's hours or years and years and years and years and years of clinical experience that come together to work through these really complex cases. One of the things that struck me in the heart or in the feels was that we were frustrated that there was, people that couldn't get to us, and we couldn't, be there talking about. And so that's the motivation and the inspiration for doing this podcast, is to give you guys some data, some information, some empowerment, right? To go out and keep seeking answers to why you're not feeling well. Maybe you're in a state of homeostasis that is conducive to staying in illness, and look at those little things that we can do to help lift you up and over that mountain and get you in that right direction. And so we want you to hold on to hope. We want you to know that we are unwavering. I mean, you don't have to talk us into maintaining a candle in the window for you all, period. But we also want to be here to help. So Dr. Klimas, I cannot thank you enough. I can only promise you one thing, and is that I'm going to steal you as much and as often as I can. Our community really, really values your generosity with talking to all of us out here. It's just really, I've got takeaways. I've got things that I'm going to be asking for my own health. And I know that there's so many people out there that this podcast is going to help. So thank you. I appreciate it. And I will see you soon.
And Haylie, I'm going to thank you on camera to make it all happen, because you and the amazing team behind you, we've been talking about doing this for years, but we didn't know how, and you've taught us how. And look we're really finally reaching out to a whole lot more people than we could have taken care of one by one. So thank you.
And I would love it if we were all out of business and nobody needed us. But until then, I have a bunch of
grandchildren who just want hugs. I could do that.
Until then, we're going to be pounding the hope and spreading the help. And that's just what we're here for. So thank you. We will thank you again. I appreciate every moment that I have with you. Thank you.
All right. Take care, y'all. Bye-bye.